Hi, I'm Dr. Edna Acuna, wound care specialist. Come partner with us at GRMC.
GRMC, where patients are partners.
The following program is sponsored by
The Breakfast Show with Patty and Ray on News Talk K57.
8:48 News Talk K57, goofing off in the studio while the spots are playing. Margaret Bengzon is with me, Francis Santos, and Alan Fontanilla, going over bits and pieces of the hospital system. And I think we've covered everything, and I don't know that I've got any more gush left in me for the technology and the layout of the building and all of these cool things. It's going to come down to I can describe it as much as I want to. I can even take pictures and put them on Facebook. I did, but nothing will replace the feeling that you will get as you walk into those doors for the very first time and see what they've laid out for you. The first time that you go visit somebody that's a patient at the hospital, maybe the first time that you bust your arm playing softball or something like that, and you find yourself in the emergency room there. I think it's going to change your own expectations of the facility for sure. There's a couple of things that people have heard about. We've talked about it, and you were very transparent about it. One of the particular delays that took place a little bit earlier in the year had to do with a construction technique whereby you take two pieces of rebar and stick them together, and hopefully they stay stuck together. There were issues with your rebar. What was it? What is it? They sell them at Home Depot, I think. What's it called?
They're called coupler systems.
The rebar coupler systems, yes. and so you had some issues with those, but they've all been taken care of.
All taken care of. That whole issue with needing to replace the rebar, because really what the source of the problem was that rebar has a male part and a female part, and the male part didn't exactly match the female part, which is always a problem, as you can imagine. So we had to dig those up. Thankfully, I mean, if we talk about half full situation, thankfully this was uncovered before we started seeing patients, because if we had been open, and this thing came up, it would have been a major problem. So from that standpoint, it's good that these problems did emerge before we opened, and we were able to get them rectified, and we got them rectified to the satisfaction of all the regulators, so that's behind us. That's done. Okay, so one of those issues that came up, it was dealt with, and it's not like we were trying out some kind of new technology. The rebar coupler technology has been used for a long time. We just had some issues around here, and that explains why there's still some construction going on around the elevators in the central portions of the building. They were the last to get taken care of, right? That's right. If you take a look at the building has essentially the structure is there's a west wing and an east wing and a central corridor, and where the rebar had the greatest impact was really on the central corridor. So the finishing work, and it's really just finishing work, tile work and ceiling work, has lagged behind the west and east corridors. Yeah,
and it's surprising when you go through there, because there's so many. It's odd because this part here all done, all taken care of, and over here you still have some guys, like I said, spackling a wall or doing something, but it's all finished work and somebody's punch list. I saw your contractors around the place yesterday, and they're a haggard-looking bunch, but they're almost done with the project, and eventually we'll open the doors. There's more conversation in the last 24 hours about MERS in this town, and you're talking about heading back to that part of the Middle East where there seems to be some of that. What are the contingencies in your hospital? Margaret, you can answer the question, but I can see the wheels turning around in Alan's head already. What are we doing about those kinds of scary diseases? Tell me about the lab situation. Tell me about isolation for patients and that kind of thing.
Well, similar to when we had the Ebola scare, we will have to have, through the infection control program within the hospital, have readiness and preparation plan for this as well.
And we do. You do?
Yes.
Okay.
So We probably need to put more emphasis on it now that I'm hearing this from you, actually. So thanks for that.
Yeah, the CDC and yeah, funny. I was just talking to James Gillen about this the other day, and he said, "Don't bring it up, don't bring it up, don't bring it up." But I guess there've been a couple of new cases reported, and people are beginning to see it, flourish a little bit more on the social media, and that will probably spread around faster than any kind of disease that the CDC is watching. But as is the case, if there is a requirement for that kind of care, you'd be capable of delivering that care.
Yeah, in each of the units or floors or wings that Margaret mentioned, we do have designated rooms for isolation, and with personal protective equipment in place, we should have an education of staff, of course. We should have no problem dealing with those kinds of issues.
Yeah, just make sure that you get everybody running around and got hand sanitizer or something like that. Correct. I think that generally takes care of those kinds of issues. There's the technology that I saw in there. Liz said the gee whiz high tech stuff that's in there is obviously wonderful to look at. But I also note that there is other kinds of imaging that you have available and other things that we're doing. Heart, we talked about hearts. We talked about transplants. Didn't spend a lot of time talking about the backbone that you've got there for cancer care and the oncological tools that are available. Margaret, if we could spend a little bit of time talking about that, so the next time somebody comes up with cancer, they don't have to leave to get treatment.
Well, the thing about cancer is that cancer is a whole program, and cancer actually begins with screening and early detection, and the best chance you have of beating cancer is finding it early.
Yes.
So when you think about a cancer program, we're thinking about end-to-end solutions from smart community screening programs, which are happening actually outside of the hospital setting in the communities, to good early detection systems, which are mainly imaging facilities that we have on board, and then treatment in terms of radiation therapy, which our equipment is second to none. And chemotherapy.
That's that linear accelerator deal that we were talking about that it provides a very unique opportunity. And I say unique because as far as I know, this wasn't something that they were talking about a couple of years ago. This is very, very new technology, cutting-edge stuff, where you want to give the patient a dose of radiation where the cancer is, but there are some cancers that, because of their location, move. The patient breathes. Or there's a reaction. There's something going on with the patient, and in the old days that just meant that the radiation went to another part of the body that wasn't the cancer. But now you've got a piece of technology that hyper targets.
That can track the moving the patient as the patient moves, and so the gantry is tracking the patient and making sure that the radiation hits only that part of the tumor that's dangerous and spares the healthy tissue.
And now the other part of this is that's one treatment for cancer. As you point out, we've got the radiation and state-of-the-art radiation. What about chemotherapy? Is that old tech? Is that or did you need to do things and beef up your lab to be able to take advantage of the new chemo therapies?
Well, the thing about chemotherapy is that there are traditional models of sort of the one-size-fits-all chemotherapeutic approach, and it's important. There's more and more appreciation over time of understanding the cancer at the molecular level, and really realizing that each person's lung cancer, for example, is different.
Yes.
And how do we understand that specificity at the level of the molecule, and how do we manage that cancer at the level of the molecule? So it really has to do with molecular level profiling and molecular level diagnostics.
I met the guy that's doing that. Yeah, and they come out here from time to time, which goes back to the other networking conversation that I want to get into. We've all got relationships one way or the other. Medical City in the Philippines, GRMC here on Guam, Tripler in Hawaii, and I think Spencer Kerner, of course, over at Cedars-Sinai. Great friend of the healthcare industry here on Guam from top to bottom. collaborative efforts for the patient. If there is something that they need, expertise that is available off island, we can collaborate on the care.
Absolutely, and like I said, it really goes back to the idea of a network and the idea that we don't have to have everything on Guam. We have resources that are outside the island that are accessible thanks to technology, and we want to maximize that. We want to utilize that to the maximum.
Well, June the 23rd is the moving target date for the grand opening of the hospital. We'll watch and see if you can hit that. I'm pretty sure you will this time. But the other question, I kind of teased on this earlier. What's phase 2?
Well, phase 2 is the second wing of the hospital. There's space on the footprint to build another upwards of 130 rooms. And we're looking to that, as we get full up and as the Guam needs grow, which it will, and as we
it's
begin.
A forward statement. I'm not going to hold you to it, but yeah, what kind of things will we see besides the beds in this other wing? What are you looking around going, wow, we should have put that in the first?
Well, medical technology, as you know, is moving so quickly, and we need to keep up with that. We need to keep up with that, and it's not just. And I always keep emphasizing this, it cannot just be about hospital acute care. It needs to be about, taking care of the patient throughout the continuum. And as much as possible, keeping him healthy so he doesn't need hospital care. So our focus needs to be on that. Prevention, health promotion, even living well in the face of chronic disease, for example.
Yes.
Which beleaguers huge numbers on the island.
Will you keep the clinics open?
Yes,
okay.
We will keep the clinics open, and like I said, the clinics will be more focused on those physicians that are primarily outpatient practices, and the ones that need inpatient support will be moved to the hospital.
Francie, you've seen the past for healthcare here on Guam. What are your thoughts on the future?
Well, the one thing that, if I can segue into what Margaret was saying, one of the big issues I think confronting us, the behavioral issues that we're facing. What we've been approached on multiple levels to see what TMC can do /GRMC at that particular type of health issue that's really impacting our island. I mean,
and has for many years.
Oh yes,
yeah.
And we've kind of again buried our head in the sand.
We're ill-equipped to take care of that.
Absolutely, and I think what like she said, it's there. We can see that, and I think as she said, let's get this hospital open and we can move forward on yet phase 2. And whatever project we need to move forward that will benefit this community.
And that's taking care of that big gap on beds that we seriously need to address as well. We're KGUM Agana. Thanks so much for spending so much time with me this morning. I appreciate the hospitality and the tour yesterday, and can hardly wait to the time where you call me and say, Judy's picture is up, and it's time for us to open the doors. This is KGUM.